Good evening, everybody. It's wonderful to have you guys join us tonight. My name is Dr. Siobhan Statuta. I'm going to be moderating tonight's session, and we're going to be discussing ankle and foot dislocations with Dr. Joseph Park, who is not only a friend but dear colleague of mine at the University of Virginia. So just a couple of reminders. This is the National Fellow Online Lecture Series, and if you couldn't join us live, you can access this in full on the YouTube channel that's provided to you through the AMSSM. Couple of goals. This group exists to serve as an adjunct to your individual program's educational programming and to provide fellows with direct access to educational experiences with experienced AMSSM members, and at times invited guest experts like we have tonight in a variety of formats. So our goal is to have these talks assist you in your CAQ exam preparation. Couple of rules to discuss tonight. Please mute your device's microphone and turn off your video. Submit questions through the chat function, include your name and program if you wish. But at the end, what I'll try to do is loop back and ask the questions during the Q&A based on the questions you submit. And then after the program, please complete the evaluation, which will be sent at the end of the lecture. So tonight, again, we're going to be hearing Dr. Joseph Park speak on ankle and foot dislocations. And it's my honor to introduce him. Mr. Joseph Park is an associate professor and foot and ankle division head at the University of Virginia Health System, where he serves as a team physician and foot and ankle consultant to UVA athletics. I can personally attest that he is used all the time and is our go-to foot specialist. In 2001, he was appointed to the American Orthopedic Foot and Ankle Society Foundation Board of Directors, and he is the chairman and host of the AOFAS Orthopodcast Committee. Dr. Park is a reviewer for the Journal of Bone and Joint Surgery, as well as Foot and Ankle International. His clinical interests include foot and ankle injuries in collegiate and professional athletes, tendon and ligament reconstruction, tendon transfers for neurologic disorders, ankle replacement, and complex deformity correction arthrodesis. Now, Dr. Park holds a secondary appointment in mechanical and aerospace engineering at UVA, and his collaborative research involves the characterization and testing of orthopedic implants, including total ankle arthroplasty. So without further ado, I'd like to turn this over to Dr. Joe Park. Let's see if I can switch my screen over. Joe, thanks for joining us tonight. And while you try to share your slides, very good. So management of foot and ankle dislocations. And with your mechanical and aerospace engineering, this is going to be dislocations in outer space or dislocations?
Yeah, I mean,
I'm going to turn this over.
Yeah, it's a very kind introduction, and just so the listeners out there know, Siobhan has taught me so much about taking care of patients and athletes too. So, you know, I view this as an honor to get to participate in this. But I always enjoy getting to spend time with our team at UVA, and this is an actually interesting talk. I put this together after Siobhan asked me to give this talk, and so it's not sort of a canned talk that I've given 1,400 times. So I thought it was very interesting. It's a big overview. There's a lot of different types of injuries that this includes, and so briefly, these are my disclosures. Mostly, as Siobhan stated, we are both team physicians at the University of Virginia. And it's really been an honor to be involved in care of these student athletes. But briefly, we'll go through the general concepts and management, talk about ankle dislocation and fracture dislocations, subtalar dislocation, Chopart's joint dislocation, tarso-metatarsal dislocation or Lisfranc, metatarsophalangeal dislocation, both Hallux MTP, also usually termed turf toe, lesser MTP joints, and then toe interphalangeal joint dislocations. And I'm going to focus really on ankle, TMT or Lisfranc, and turf toe. I think For orthopedic foot and ankle surgeons, these are probably the three kind of most common things that we have to operate on this list. And so, if you guys have a good overview of this and when to try to treat it and when to refer pretty quickly, I think that's hugely helpful. But as Siobhan knows, we're part of a big team that helps care for these athletes, and the sooner we can get advanced imaging or get them in front of the right specialist, whether it's spine, sports, our hip doctors, knee, and for foot and ankle as well, I think it really helps these patients get back on their road to recovery. So just going through general considerations, some of these injuries are pretty obvious. And if you see a patient with an obvious deformity after a dislocation, consider a gentle reduction attempt. If you can't reduce it, obtain an X-ray. And this can often be very difficult because of how much the patient is hurting or guarding. And often it will require removal of taping, bracing, and a shoe to assess the severity of the injury. I think sometimes it's a hard decision to kind of cut through all that tape and strapping and all that. But I think if you have a bad injury, you should definitely get in touch with your friend, your orthopedic surgeon, who can help with any urgent care as necessary. But really the goals are pretty simple. Stabilize the extremity, elevate, ice, and then apply gentle compression. And remember, these injuries typically require a significant amount of energy and force to disrupt the ligaments and joint capsules. So check for vascular status. Make sure the pulses are there, the temperature is equal to the opposite side, the color of the extremity is appropriate. Make sure it has good cap refill, and always, as I said, compare to the opposite side. If there's any issues with skin compromise, if there's an open injury or pending skin necrosis, which can happen in some of these bad dislocations, that's when you need to start thinking quickly about getting these dislocations reduced. Check the nerve function. Sometimes these patients will have a pretty profound nerve deficit. Hopefully it's transient, but sometimes the quicker you get them reduced, the better they are in returning that nerve function. If they have a lot of swelling, think about foot compartment syndrome. We don't always address this issue surgically, but sometimes it does require delayed treatment if the swelling is very, very bad. And remember, this is just a reminder, if you see an open injury, remember that the delivery of IV antibiotics, whether it's ANSEF or ANSEF and GENT, as well as tetanus, have a huge effect on the outcome from these bad injuries. Remember that reduction of dislocation may require sedation or general anesthesia. You have to recognize limb-threatening fractures and dislocations. On the right, you see Alex Smith. He's in his spatial frame or external fixator, which was a result of a pretty horrendous injury and then complications related to his surgical treatment. Remember to follow damage control protocols and to respect soft tissues. Splinting and non-weight bearing and putting someone on crutches is always a safe answer. I think if in doubt, if there's a lot of swelling and the patient's uncomfortable, I think this is always a safe answer. And I think, reviewing a lot of medical legal cases, I think it's always easier to err on the side of being overly cautious. So starting with ankle dislocations, remember that these are very rare to occur without fracture. However, they can occur, but it involves severe ligamentous disruption. And often it requires dislocations that will disrupt the deltoid, the lateral ligaments, the ATFL, CFL, and PTFL, as well as the syndesmosis. So these are pretty horrendous injuries. Typically, they're in plantar flexion and inversion with a significant axial load. The picture you see on the lower right is actually the opposite. It's actually a lateral dislocation, which is quite rare. Some of the risk factors of these dislocations, again, usually it's from an inversion mechanism, come from medial malleolar hypoplasia, ligamentous laxity, as well as peroneal tendon weakness. These ankle dislocations typically require a closed reduction under sedation and or general anesthesia. These are treated pretty rapidly, 2 weeks in a splint, followed by 4 weeks in a cast or walking boot. I prefer a cast. I think it helps to let the soft tissues rest and maintain the appropriate position. Usually then they're progressed to weight bearing as long as there's no suspected bony injury, and then initiation of physical therapy at that time, range of motion, peroneal strengthening, and avoid the mechanism by which the injury happened. In terms of complications, some of these injuries can come with it an osteochondral injury or defect, ligamentous instability over time, although I would argue stiffness is far more common if you follow these patients out. Tendon injury that includes the peroneals, posterior tibial tendon, as well as sometimes even the Achilles tendon. And if you're still having issues and the patient's still very swollen at 6 weeks, I think getting an MRI at this point is very reasonable. I think if you get an MRI a little bit too early, sometimes there's so much bony edema and inflammation that it's very hard to use that to dictate your treatment course. And then for these injuries, return to play can take up to 4 to 6 months. So going forward to fracture dislocations, which are much more common, here's a case presentation. It's one of our UVA athletes. He's a fourth-year cornerback who sustained a left ankle fracture dislocation during a game at Miami. He was reduced on the field by my partner and splinted. He was, of course, a preseason All-American, projected first-round NFL draft pick. And, you know, when you look at these fracture dislocations, it requires disruption of the ring, the quote-unquote ankle ring, in 2 places. These can happen most commonly in football, basketball, and soccer, high energy, jumping, and cutting sports. Realignment and reduction is often easier if there is a fracture, but remember that flexing the knee to relax the gastrocs can really help to take tension off of the deformity. And although bony injury is often the most obvious, ligamentous injury can be severe. And this is a picture of the deltoid that has avulsed completely off the medial malleolus. So sometimes the X-ray tells the picture, but I think the soft tissue injury can be quite dramatic. So in this case, for an ankle fracture dislocation, you try to perform a closed reduction under sedation or intra-articular injection. You should place the patient into a splint to maintain alignment. And often these, or almost always, they will require surgical fixation. So you almost always have to fix the fibula. I think there would be a very rare instance where you wouldn't have to, but you'd have to do a fixation of the fibula. The question is, should you repair the deltoid? Should you repair the syndesmosis? And should you perform an ankle scope? So these are all answers that are kind of in evolution in our field in orthopedics. I would argue that the answer about a scope, especially in a high-level athlete, in my mind is pretty clear. Dr. Hinterman in 2000 published a study where they did a scope on 288 ankle fractures, which is pretty amazing. He found that almost 80% of these patients had articular lesions, most commonly of the talus. And if you have patients with a Weber C above the ankle syndesmosis, a pronation external rotation injury, and syndesmotic disruption, such as this patient that I just showed you, a scope should be performed as the incidence of articular damage is very, very high. In addition, if the patient is going to be going to the next level for the NFL or NBA or for the combines, remember that one of the critical determinants of how that injury will be dealt with by those teams is the understanding of whether a severe cartilage damage took place at the time of the fracture. Malreduction of the syndesmosis, you know, I think this is one surgery that we really do poorly, and I think there's a lot of literature that's being written about this, but you know, in terms of the high ankle sprain and these severe ankle fracture dislocations, I think the worst thing we do, or we fail to do, is to restore the anatomy of the syndesmosis. That we know that manually reducing the fibula into the incisura is better than using a clamp. Direct open visualization allows for better reduction. Remember that if you use a large bony clamp and a screw, you can malreduce it up to 50%, which was in a study published in 2006. Intraoperative CT scan can really help us too, but it is not universally available. It is available at UVA, and I and my partners use that sometimes to help us with these very challenging cases. In terms of syndesmotic fixation, there's not much literature supporting many different choices when you choose screws. So it turns out that the size or diameter of the screw doesn't matter. The number of screws but probably doesn't matter. The number of cortices of fixation probably doesn't matter. So none of those things have been shown to affect outcomes or loss of reduction. A suture button, which is 2 metal buttons with a very strong suture in between. The Arthrex tightrope is the sort of quintessential suture button implant, the one that is advertised everywhere, such as with Tua when he injured his ankle. but there's definitely a higher chance of overcompression when you put two of them as opposed to just one. And there are some thoughts that this may not help us as well with insufficient control of the fibula, and it may predispose to shortening if the fibula fracture is length unstable. Remember too, just the way that implant is placed, you may see in some of your athletes that where those that needle comes out medially, the nerve and vein are at risk at that medial exit. I do think it's better at reducing than the screws because of its flexibility, but it's a large drill hole and there's definitely a risk of stress fracture. So this is the technique I've been using for the direct AITFL repair for some of these fracture dislocations. I use a docking technique. So I take suture anchors in the fibula and I dock them into the tibia at the Chopart tubercle. And you can see there on that lower left-hand picture, if you imagine that the posterior ligaments are intact, my theory is in order to control external rotation, you can just compress at the anterior aspect of that syndesmosis and you can prevent external rotation. Deltoid ligament, I think we are much more aggressive about fixing these ligament injuries in our athletes. Rosa et al. Did a very nice study looking at ultrasound and stress x-rays, and they found that 5.8 millimeters was consistent with a complete deltoid tear where partially torn led to 5.2 millimeters of clear space. So in my practice across the board, if I have 6 millimeters of medial clear space on any view, including the fracture view, they're getting a deltoid exploration and repair in my hands. And thus far, using 6 millimeters has led to 100% of deltoids found to be avulsed off of the medial malleolus, as I show in this picture on the left. The sutures are clamped until I fix the fibula anatomically. My mentor and colleague, Dr. Bob Anderson, who, long story short, Dr. Anderson was in Charlotte and, he acted as a huge mentor for me and helped me early on in my career. But essentially, Dr. Anderson is the foot and ankle surgeon. If anybody in the NFL or NBA is having surgery, there's a very high probability it's Dr. Anderson or one of my other mentors, but it's very humbling to have had mentorship like Dr. Anderson's. But nevertheless, he looked at these similar types of injuries that were sustained in the NFL. So bad ankle fracture dislocations. He treated them all with an ankle scope, fixed the fibula, did a tightrope, and then repaired the deltoid. He looked at 14 NFL players. 86% of those returned to play, and all returned to running and cutting by 6 months post-op, and none had medial pain or instability. The average follow-up was almost 2 years. And again, here's a picture from his publication, and you can see how eerily similar that image is compared to what I just showed you for one of our athletes. So the plan was 2 days after injury, he was brought to the UVA hospital and we performed this procedure for him. I did do an ankle scope for the reasons I mentioned. I fixed his fibula using this plate seen on the right. I reconstructed his deltoid using suture anchors. I then did my direct repair for the syndesmosis. Here's his ankle scope. You can see all the angry tissue back there already, but the chondral injury was very, very minimal, just some minimal scuffing on the back of the talus. The rest of it looked very good. So post-op, I kept him off it for 6 weeks, 2 weeks in a cast. 2 weeks in a splint, 2 weeks in a cast after that. And then I let him walk in the boot and begin range of motion. I let him return to running and cutting activities by 4.5 months after surgery, non-contact only. He did miss the combines because of COVID-19 and the UVA Pro Day was canceled. As those of you remember, that was a pretty crazy time to take care of athletes anywhere in the world. And he was cleared for full football activity 6 months post-op. I don't think he was at 100%, but we let him go back to full football activities. And he eventually was drafted in the 5th round by the New York Jets, which was lower than he was expected to go. I'm sure, they were not sure how he was going to recover from this. But he did return to gameplay 10 months post-op, which I would argue is within the range of what I think is normal for this type of injury. And in that game, he had his first interception and had an amazing game. And thus far, he's done extremely well coming back from this injury. So going forward, or more distal into the foot and ankle, the subtalar dislocation is when you dislocate the talocalcaneal or subtalar joint, as well as the talonavicular joint. It makes up 1% of all dislocations. On exam, the foot can be locked in supination for a medial dislocation, or pronation, which would be a lateral dislocation. I think medial dislocation is way more common. Treatment, you can attempt a gentle closed reduction. Again, flex the knee to take pressure off the gastrocs and plantar flex the ankle. This will again often require general anesthesia because they will be in quite a bit of pain. I would get an X-ray and then a CT scan, certainly, and here's a clinical picture of what some of those dislocations can look like. But often these require an open reduction. A medial dislocation, you'll have to make a lateral incision to remove all of those lateral tissues that are stuck in the joint that make it so that it won't reduce. And the opposite is true for lateral dislocation. We make our incision medially and address the tibialis anterior and posterior tibial tendon to remove those structures from the joint. If the dislocation is stable at that point, you can place the patient into a splint. But if they're unstable, you can put them into an external fixator or put K-wires across the joint if very unstable. At that time, you would obtain a CT scan to characterize any osseous injuries or malreduction. Associated fractures are quite high, so 50 to 100% of these injuries in the literature, as is true of many injuries that result from, let's say, bad decision-making. It's way more common in men than women, about 10 times more frequent in men. Typical high energy mechanisms, so fall from height, motor vehicle collision, and high energy athletics are the most common. Remember that it's described regarding the displacement of the distal foot relative to the talus. So medial dislocation, as I said, is about 80% of the time. Lateral dislocation is 17%, and the remainder are either posterior or anterior, both of which are extremely rare. In a lateral dislocation, it typically requires higher energy because it involves a significant osseous injury or open soft tissue injury. 23 patients were treated who did not have a fracture in this study by Jungbluth et al. 13 underwent splint and casting after closed reduction. 10 required an external fixator. There were 7 patients who were taken there because they were irreducible or an open injury. 2 lateral, so they had displacement of the posterior tib and FTL to the lateral aspect of the talar neck. And then 5 open medial dislocations. The talar head had buttonhole through the extensor retinaculum or the extensor digitorum longus tendon. And then they had 2 more that were irreducible, even though they were closed injury. And 1 patient had massive swelling after closed reduction. So typically these are treated again, 6 weeks of immobilization and then progress weight-bearing physical therapy. Usually they're full weight-bearing by 10.5 weeks, and they can return to work in this study by 10.3 weeks. And then this study, they found, again, no decrease in sports activities or restrictions. Those patients who were treated in cast or brace, their AOFAS hindfoot score was 83.3, and X-fix patients was slightly lower, although not statistically significantly different, at 80.9. There was no restriction noted in subtalar motion. However, 9 out of 23 did demonstrate mild degenerative changes at full follow-up. Moving forward, again, down into the foot, Chopart's joint dislocation. So it turns out that this injury, it takes an enormous amount of force to have this injury. It involves the transverse tarsal joints, the talonavicular, and the calcaneo-cuboid joints. It is named for a French urologic surgeon named Francois Chopart, who lived from 1743 to 1795. This is one of the most severe injuries you can have in the midfoot or hindfoot and has probably the worst prognosis. There's always significant swelling and pain with this injury. Closed reduction is often extremely difficult or impossible. And in the study by Richter et al. In 2004, these are all high energy injuries. So 82% of them were from a high speed motor vehicle collision. 9% were from fall from height. And closed injuries were 82%, and open injuries were actually 18%, which is actually quite high if you think about it. 25% of these were polytrauma patients. Closed reduction was successful in 19 out of 110 patients. That's only 17%. Surgical treatment, which was obviously much more common, closed reduction internal fixation was successful in 14%, or 15 out of 110 patients. Open reduction, or making an incision and then reducing it and fixing it, took place in 58%, or 64 patients. And primary amputation was 12 out of 110 patients, or 11% of the patients. That's a significant number. And actually, if you follow these patients through in this study, if you read carefully, another 3 patients had an amputation, so a total rate of 14% amputation after this injury. So this is one of the most severe injuries you will see in any sports medicine field. And so just have a high level of awareness and fear if you see this type of fracture dislocation. Their average AOFS score was 75. The worst possible outcomes were in combined Chopart and Lisfranc fracture dislocations. There are better outcomes with open reduction internal fixation as compared to closed reduction. And 3, again, as I said, after treatment led to a below knee amputation due to infections that could not be treated appropriately. So Lisfranc dislocation, another common injury that you'll see. Again, another French surgeon and gynecologist, Jacques Lisfranc de Saint-Martin. He in this, the first description, he performed an amputation through the tarsometatarsal level after a soldier dislocated his foot during a fall from a horse during the Napoleonic Wars. So the take-home message from the Chopart and Lisfranc dislocations is that if your injury is named after a French surgeon, you're really in trouble. And we've had a lot of trouble having great outcomes with the Lisfranc injury in many of our athletes. Specifically, Lisfranc dislocation refers to the disruption of the articulation between the medial cuneiform and the base of the second metatarsal, but really in our literature and colloquially, it expands to include any disruption of any of the tarsometatarsal joints and including the inner cuneiform and navicular-cuneiform joints. It's about 0.2% of all fractures. The mechanism is often high energy. Motor vehicle accidents fall from height. And some of the low energy ones from sports would be especially from football, which is the most common time I see a Lisfranc injury. You can get it from axial load and rotation through a plantar flexed forefoot. And typically the metatarsals displaced laterally and dorsally, just given the mechanism of the injury. In terms of the Lisfranc ligament, remember that the interosseous ligament goes from the medial cuneiform to the plantar base of the second metatarsal. That's located here, as you can see in this image. The plantar TMT ligaments are stronger than the dorsal TMT ligaments, which is why when the injury happens, it usually leads to a dorsal displacement of the metatarsals. The intermetatarsal ligaments go between the second and fifth metatarsal bases. It is absent between the first and second, which is why I think these injuries are more prone to happen in this location. And remember, the second metatarsal fits into the keystone between the medial cuneiform and the recessed middle cuneiform. And here's that keystone. You can see, if you imagine that second metatarsal pops out, it then destabilizes the whole midfoot. So on exam, these patients will have that classic sign of that plantar ecchymosis. They'll have swelling, tenderness, palpation at the midfoot. Often these patients are not able to stand or bear weight on their foot. They will have instability if you do a dorsal stress test. Often you can't even do this test because they get so swollen, but right after the injury, sometimes you can feel that instability. And often these patients will start to get pronation and abduction of the forefoot. That's the classic sort of deformity that can result. And these patients should always get x-rays as their first line imaging. You should get weight bearing if possible, although many times, again, these patients are quite tender. And then a CT MRI can be done to look at bone and ligament anatomy. So looking at Lisfranc dislocation, I think, again, putting them on crutches and making them non-weight bearing is a very reasonable first step, even if you're not quite sure what the mechanism was or if it was enough force to cause this injury. If they're tender there and they have any amount of pain and swelling at the midfoot, I think putting them on crutches is a good first step. You can cast for 6 weeks if it's non-displaced on a non-weight bearing view and only has minimal displacement on a weight bearing view. And I've probably treated over 100 patients that way in 11 years. I think it's a pretty common thing. And I don't fix all of them. I think they've done very well as long as you can sort of utilize that inflammatory period to obtain some scarring and healing. They seem to do quite well. In operative treatment, if they're very swollen and you cannot do a definitive ORIF or arthrodesis, you can temporarily close reduce them, put them in the proper position, and then put some K-wires across those joints. That is not a great definitive treatment. The outcomes from that technique have not been great historically. In terms of fixation versus fusion, I believe it is still controversial at this point. Some of the controversies involve whether or not you should remove the hardware. Some patients will receive fixation and they will not take them out. So even though we haven't done a fusion, they will still have hardware across a joint. And many times, especially in athletes, will leave those in. And the other thing is development of arthritis. I think it's, as I tell my patients, if you have this injury, the chances you develop some degree of arthritis is nearly 100%. It's just a matter of how bad is it and how fast or quickly does it come about. And so I think by fixing it perfectly, you do slow this process, but these patients will develop some arthritis later. I put these in quotes, but young athletes should undergo open reduction internal fixation. I don't know that there's a number cutoff. I think it more has to do with, how competitive they are, how important it is to them. And then quote unquote older or severe displacement high energy mechanism, I believe do better with an arthrodesis. And at my age, I'm close to 45 now. I believe that I would rather have an arthrodesis than fixation, just given the literature out there. So here's a case presentation of mine, 22-year-old JMU, that's James Madison University quarterback. That's a school about an hour from Charlottesville, who sustained a twisting injury to his left foot during a football game. He was unable to bear weight, although he did try to come back in that game. He had significant swelling and plantar ecchymosis. And you can see on this x-ray, this is a comparison view, but you can see that this left second metatarsal is displaced probably 4 millimeters or so laterally, okay? And so that patient underwent urgent Lisfranc fixation as his swelling allowed about 7 days later. And in this case, you can see that he had fixation not just of his second TMT joint, but I also had to span his first TMT joint as it was unbelievably unstable. And he had diastasis coming both this way in the inner cuneiform joint and then this way out of the navicular-cuneiform joint. So this was a very high energy injury. I took his hardware out about 4 months post-op, and he maintained his alignment quite well, had reasonable arch support and arch alignment, and he was able to go back to football. He did play in the CFL for a few seasons, but did not have a long career in football. So the outcomes in the literature, I think, are pretty sobering, but 44 of 61 who had this injury had radiographic osteoarthritis. 54% of them were symptomatic. Some of the risk factors were non-anatomic reduction, smokers, and severe displacement. And some of the complications that were seen were infection, malunion, flat foot deformity, and arthritis. I strongly believe that delayed arthrodesis can still yield excellent outcomes. In my practice, I think I treat a missed Lisfranc injury, it could be decades prior, but I'll treat a missed Lisfranc injury maybe once a month at least with an arthrodesis procedure. Here's a patient of mine that I had to do that for. Moving forward, let's talk about Hallux MTP dislocation or turf toe. I put this picture of Patrick Mahomes because those of you who follow football closely probably remember, he sustained a severe turf toe injury in the playoffs, and I didn't realize how bad it was until after the Super Bowl. I learned that my colleague, Dr. Anderson, fixed Patrick's turf toe, I think 3 days after the Super Bowl. So clearly, he was not going to be able to play his optimal game, and I think that was very clear watching that Super Bowl. But it is a very debilitating injury. So it's a high energy injury that results from hyperdorsiflexion of the hallux and axial load, often a valgus load as well. The presentation is severe swelling and ecchymosis. Often these patients have a hard time flexing the great toe. The reduction for this is to plantar flex the MTP, put them in a little bit of varus, and you can do a hallux valgus taping to prevent valgus and dorsiflexion dislocation. I would again make these patients non-weight bearing with crutches and a walking boot. Here's a picture of what that mechanism looks like classically. You can see that hyperdorsiflexion load under an axial force. This is from one of our publications that we did at UVA looking at turf toe. But it's really, when you're thinking about the quote unquote plantar plate, it really refers to these sesamoidophalangeal ligaments. And so when you hear the term plantar plate, it refers to the tissue that connects the sesamoid to the base of the proximal phalanx. On clinical presentation, again, there's a lot of swelling ecchymosis. They have pain with weight bearing, especially on toe off. You should see where they hurt. Sometimes it's in the joint, sometimes it's plantarly. Check their range of motion, passive versus active. Rule out a dislocation or severe subluxation. You can do a dorsal stress test or varus valgus stress test to evaluate for instability, and look for an intrinsic minus foot, and that's where the toe is, the MTP is extended and the IP is flexed down, and that indicates disruption of the flexor hallucis brevis tendon, which is secondary to that plantar plate rupture. I always check for strength of MTP flexion. I think a patient who cannot flex through their MTP, they will be very, very limited from an athletic standpoint. And here's a picture of a dislocation, dorsal and lateral. On weight-bearing x-rays, you should get AP, lateral, and axial sesamoid view, as well as an oblique view to look at the sesamoids. There's a good study that showed that if the sesamoids are retracted medially more than 1 centimeter and laterally more than 13 millimeters, it's 99.7% sensitive for a plantar plate rupture. So I think that's a very good test. X-rays may show diastasis of a bipartite sesamoid. I know many of you guys have seen what that X-ray can look like. But a stress dorsiflexion X-ray can show increased diastasis on a lateral or AP X-ray. In a non-bipartite sesamoid, if the plantar plate is completely ruptured, as you dorsiflex the toe, the sesamoid will not travel with the phalanx and will remain proximal to the MTP joint. And I'll show you guys a picture of that too. A bone scan, I'm not sure many people get bone scans at this point. I think it's not a great test because sesamoid uptake is present in up to 30% of normal individuals. A CT, I think, is a good move to look at fracture margins if you're concerned about a fracture. And you can look in the joint of the MTP joint to see if there's any osteochondral fragments. I believe MRI is by far the gold standard at this point to look at these injuries. You can look at fracture lines, plantar plate complex, look at the FHL tendon, look at vascularity of the sesamoids, again, chondral injuries, and then bipartite sesamoid. It's a good test to look for all of those things. Dr. Anderson wrote these grade 3 grades and looking at these injuries, and essentially, grade 1 and 2 are partial injuries and often will not require surgery. I like to tape these patients in plantar flexion, so just holding the toe down. I really start early range of motion, especially plantar flexion right away, and I like to do strengthening. Just have the patient keep curling the toe, including the big toe and small toes, the hallux and the lesser toes. And in my experience, return to play for a grade 2 can take at least 2 weeks, but sometimes 6 weeks, so you have to follow them closely. We will use a carbon fiber Morton's extension, which just goes along the first ray to help stiffen that ray. Not every patient can tolerate that. For grade 3, which is the most severe type of injury, these patients can be casted or immobilized with plantar flexion of the hallux MTP for about 6 weeks. I would argue that in a patient who has sesamoid migration or severe injury or instability, or they're a high-level athlete, you should strongly consider surgery for that patient. And if no improvement with immobilization, therapy, or taping, you can also then return to the operative protocols as well if they're just not doing as well as you think. If they have a bipartite sesamoid, this is not an uncommon thing. I see this so many times in our basketball players and football players. They've probably had it their whole career, and sometimes it's a relatively benign injury that can spark issues with that sesamoid. But if it's a turf toe injury, it can be tough because what happens is those two bones separate. And in my experience, I think casting, and this is again per Dr. Anderson, his mentorship to me, but casting and taping has worked far better in that case. So as I like to do another case presentation, this was a 18-year-old UVA center fielder who sustained a significant right hallux MTP injury when his toe got jammed between the ground and the outfield wall while trying to catch a fly ball. His toe got stuck in dorsiflexion and was reduced by the trainer. He was treated in a cam boot since that injury. I saw him 3 days after the injury, had a lot of swelling. He was able to flex at the IP and MTP, but he had significant pain, and he had pain with passive extension of the hallux MTP. He did not have a significant varus or valgus deformity, but he did have pain with valgus stress. So if you look at these x-rays, you can see that even just looking at the AP, that these sesamoids appear somewhat retracted. And you can see on the lateral, here is the sesamoid sitting here compared to the proximal phalanx. It's quite a bit separated. And as we discussed, if you do a flexion, a dorsiflexion lateral, you can see that the sesamoid has not tracked with the phalanx, but has remained in its original already retracted position. I think that's a great sign to look for. I think it's difficult to stress the patient if he has a lot of pain, but I think if you see that, it's a definitive diagnosis for a complete plantar plate rupture. MRI also showed the same thing, complete rupture of both the medial and lateral plantar plate. And so for him, you know, I fixed both the medial and lateral injury using a direct repair technique. I talked to my mentor, Dr. Anderson. He told me that even if we repaired this and he had an excellent outcome, he probably would have to change his position in baseball, given the type of speed a center fielder needs. So in this case, I did, as I said, a medial and lateral plantar plate repair. I repaired his collateral ligament, which was completely blown up and avulsed off of the metatarsal. And I splinted him with his toe in 10 degrees of plantar flexion to decrease stress on the repair. Kept him off it for 2 weeks, and then I let him start walking on the heel, maintaining that plantar flexion. I let him start moving, curling the toe down at 2 weeks post-op. I slowly brought him back up to neutral, beginning around getting there at 6 weeks, and then letting them increase by 10 degrees every week. I don't want them to go beyond 30 degrees. So at that point, I just let them use their stiff orthotics with the Morton extension. 3 months, he's running and in the weight room. 6 months, he has no pain. We cleared him for full activity. The following season, he returned to outfield, returned to center field. He stole 27 bases out of 29 attempts. He led the ACC, was 9th in the NCAA for his junior season. He was batting .329 his senior year before sustaining a wrist injury. At that point, had stolen 9 out of 9 stolen bases. And he was drafted in the first round by the Diamondbacks, 39th overall. In strength testing, we did a study looking at these turf toe injuries, and it turned out that the injured side was actually stronger than his contralateral side. Just a testament again to our trainers and how excellent our communication is between the trainers and the student athletes. You know, this guy was so motivated and did an amazing job with that. So he really did very well. Dr. Anderson had similar results in his repairs. 17 out of 19 athletes were able to return to previous level of activity after the direct repair. It suggests that more aggressive treatment may be a good idea for these high-level athletes. There's not really any prospective randomized trials. It's a pretty small number, you know, and many of these are treated non-operatively still. Smith and Waldrop published this in 2018, looked at 15 competitive, mostly college football players. All were able to return to football. Most returned missed almost 4 months of football. And range of motion was excellent, and their scores were excellent. The average pain was almost 0. Moving forward, you know, lesser MTPs and IP joint dislocations, I was sort of dreading looking this up because in the hand, I know you guys see that so frequently, but it turns out that for the foot and ankle, both MTP and IP joint dislocations are very rare, so I'm going to go through this very quickly. But lesser MTP dislocations, only a few cases are described in the literature. Almost all cases are dorsal dislocation that result from tearing of the plantar plate and collateral ligaments. They can be associated with concomitant injuries like metatarsal fractures or Lisfranc dislocations. In my practice, that's where I've seen the few, probably in 11 years, I've seen 3 second MTP dislocations. Brunet and Tubin wrote this in 1997, so many years ago, but they looked at 27 dislocations. 16 of 27 were treated with closed reduction, but 8 out of 11 had to undergo open reduction. 3 were unstable and required pin fixation. Those were the worst possible outcomes for both arthritis and pain. And treatment involves reduction and taping, open reduction and pinning if that joint is unstable. I like this kind of taping where you loop over the base of the proximal phalanx and then crisscross on the bottom of the foot. I think it works very well. You can kind of tension it You don't have to buddy tape. I think it works very nicely. You can also control some, varus valgus plane malalignment. So I think that's a good option. And there's really not much else about MTP dislocations, surprisingly. You'll see chronic things in people who have rheumatoid, but in athletes, you're not going to see that very commonly. And interphalangeal joint dislocations are even more rare. So Brunet and Tubin described only 4 cases in their series. All of them involved the proximal interphalangeal joint and were dorsal dislocations. The block to reduction is always the plantar plate and sometimes the flexor tendon. And most are stable after open reduction, but they're challenging to reduce. I think the finger is very different. I think often, in our basketball players, we'll pull them and reduce them and tape them and let them go back in. I don't think toe dislocations, I don't think it's quite the same. I do think that fracture dislocations are way more common than what's in the literature. I know that in my 11 years, I've seen probably, let's say 20 people who've broken their, I think the 5th toe is probably the most common, where they catch their 5th toe on the edge of a door or a couch in the dark, and it dislocates the IP joint or PIP joint through a lateral small fracture dislocation. And many of those patients, I've had to fuse their IP joint in a delayed process, much like this image here on the right. So if you have arthritis or a deformity, which often these are missed, but you can always do an IP fusion using K-wires or other implants, just like a hammer toe correction. So thank you very much for listening. It was a lot to go through in one night, but this is our UVA foot and ankle division. I'm very happy and proud of our team that we have at our university. But Dr. Cooper, Dr. Karamal, Jim Shorten, Andrea White are our PAs. And just to put a plug out there, as Siobhan mentioned, I am chairman and host of the AOFAS Ortho Podcast Committee. And so we have a podcast that's released every week. And we try to interview some of the giants of orthopedic foot and ankle surgery, people like Bob Anderson, Martin O'Malley, Tom Clanton, a lot of the people who have, paved the way for people like me to get to do this job. So again, thank you very much. If you guys have questions, you can forward them to Siobhan or email me directly, and I can answer them for you. But yeah, thank you very much, Siobhan. It was really an honor, and let me know how I can help.
Thank you, Joe. Thank you so much. I'm gonna, if you don't mind, I have a couple of questions for you, and then
Sure.
what I'll do is, if we have members of the audience that would like to ask a question, go ahead and put that in the chat. But Joe, okay, so
Yes.
here our audience is primarily fellows and people getting ready for the boards. So they're on the sidelines. What is the one thing, what's the pearl that they should not miss? So I know, very open-ended question, but
yeah.
Is it neuro exam? What would you advise?
Yeah, Siobhan, I think that's such a great question. I think the things that I've seen, doing our jobs, I often will review some of these cases at a medical legal standpoint. And the thing that I think is the worst is minimizing an injury that's very severe. So for example, if you have like that Chopart dislocation, right? If you have something like that you don't appreciate how much force it took, I think that's where we as medical providers can get in trouble, because those are the type of injuries where you say, oh, put it in a boot and walk it off. If you know your athlete well and you are been on the sidelines and they are not behaving in the way that you would see them behave, just, I think you never go wrong by saying, you know what, I'm not comfortable with how you're looking after this injury. I'd really like to just put you on crutches and let's get a quick x-ray and then we can talk, Right. And so I think the things that I've seen go really badly, neurovascular injuries. So, this is not related to foot and ankle, but if you have a bad knee injury, for example, and you've seen this, I know, and you've helped take care of our athletes this way, but people who get a foot drop, right? They get a peroneal nerve injury at the knee. And I've seen patients who didn't know they had a foot drop for months and months. And then I see them and they have an equinus contracture and they can't bring their ankle to neutral. I think those are devastating. I think open injuries. So if you have a dislocation and you have a small poke hole that you think maybe it's from somebody's cleat or somebody's fingernail. Just if you see a deformity and an open wound, no matter how small, just think to yourself, could this be an open injury? And if it is, I think, as we said, giving them antibiotics, making sure their tetanus is up to date, and then calling your friend who will have to go to the OR or ER and meet that patient and get them fixed quickly. I think that's the scenario. So I would say, yeah, I think an open injury is not that, it's not easy to know that it's an open injury. Many times, even in our residents, they'll have missed an open fracture because of road rash, right, or something else. I think that's when you inject a joint and see if it extravasates. And I think that's I think really important.
Okay, excellent. Thank you. If you don't mind, we have a question that's come in. If the patient is neurovascularly intact and unlikely dislocation fracture, is it okay to just splint and send to the ED for reduction under sedation after getting films, or do you recommend reduction on field even if neurovascularly intact?
That's a great question. Yeah, I mean, that example I showed you, my sports medicine partner saw the injury. We all saw the injury, unfortunately.
Joe, I was there on the sidelines as well.
Yeah, so I remember seeing your
faster.
Yes, exactly. But it's funny doing this job. I mean, you probably do a better job seeing these injuries than I do. I have no problem once the injuries happened and I have to fix an open, whatever, femur, tibia, it doesn't matter. But at that point, it's fine. But the videos and things that people put on the internet of these horrendous fracture dislocations and things like that, it's something about that process. It's a visceral response for me. And I think it's just because I know, like Alex Smith, that story that he went through, my heart just breaks seeing what that guy went through. But to answer your question, I would say it's worth it to try to do a gentle reduction maneuver. So for example, if we're talking about an ankle fracture dislocation in the example that we were talking about, bending the knee, taking the gastrocs out of the picture, seeing if they can relax enough, and then just gently putting a little traction, and then, often, again, it dislocates medially, so you can kind of reduce the ankle laterally. But if you're finding a lot of resistance, yeah, don't overly pull on it. Don't try to put so much force through it. A good example too is like a shoulder dislocation, right? 90% of the time you can reduce a shoulder dislocation without a problem, but sometimes you have an interposed tendon or you have a fracture of the humeral head that you don't appreciate, right? So I think it's worth it to do a gentle reduction maneuver. And if it doesn't go back pretty easily, then I think splinting in situ and calling ahead to the ER, I think is very reasonable. But I think in many cases, like for example, trying to reduce a Chopart dislocation is not going to work. That process, you're going to need general anesthetic, and I think you'll know that pretty quickly. So but I would give it a gentle pull and just to see if it will easily reduce, as unfortunately our athlete was able, but he was able to be reduced, but it's because it was so unstable.
Wonderful, thank you. So this is a curiosity question for myself. Any midfoot acute injury, I always immediately, the hairs on the back of my neck stand up and I take it much more seriously. Midfoot gets me thinking.
Yeah.
So is it reasonable to just go straight to bilateral weight-bearing views when x-raying, or do you typically not do that unless you're concerned about the Lisfranc?
So your question is, if you're worried, does it make sense to get a routine x-ray, or should you get
early? No, x-ray, right? So there's an injury.
Right.
Foot is sore. The cuneiforms are tender to palpation.
Yeah.
So you're going to x-ray the foot. Is it prudent to advise our new attendings to always to get into the habit of getting bilateral views so that they can miss, so that they have less likelihood of missing a list?
I got you. I think that there's a big difference between what you read in a textbook and what you can actually do in clinic or even at the side of the field. And these injuries are really painful. And most of the time, right at the time of injury, they have a hard time putting all of their body weight down on it. And so that's why, again, I think splinting them, putting them on crutches, and then making sure that if you see them in your own clinic, for example, I would definitely, as backup, just call somebody and say, hey, I'm worried about a Lisfranc. I'm going to bring them back this week and repeat x-rays. But just have a low, just your threshold should be very low to get advanced imaging, especially in these high-level athletes. I will tell you that missed Lisfranc is probably one of the most common things that physicians and not always orthopedists, sometimes it's primary care doctors, ER doctors, will get sued for. I've often had to be involved on the defense side, and I've just said, look, it's not the ER doctor's job to tell you exactly what your injury was. Their job is just to tell you this is significant and you need to see somebody. And I think if you can just put them on crutches, if you think they need an MRI, then I would, call your local friend who's an orthopedic surgeon and just let them know, like you always do, like, hey, I'm really worried about this.
Thank you. I currently have an athlete, not an athlete, but a local community runner who ran a marathon, did really well, and then decided to do one of these virtual ultra events where every hour on the hours they have to run 4 miles, and she was in her upper 80-mile zone. So she was mile 87 and felt a tweak in her midfoot. So immediately x-rayed, straight to MRI, tender over the area. And so I think that even the MRI hedged a little bit. There was a little, like a minor abnormal signal in the Lisfranc. And I'm like, sorry, and treating her quite aggressively. And so these are tricky things, but I mean, somebody who for fun nearly wins a marathon and then the next weekend is running nearly 90 miles for fun, you need to take these very seriously. So it's also understanding the mind frame of these individuals, but
exactly.
Yes, don't miss the midfoot injuries as well.
Yeah, I saw there's a question about educational resources. Yeah,
I think we have, educational resources showing how to perform reductions.
Yeah, so I think if you YouTube them, you can show, some people will show you some of these reductions. Truthfully, like every one of them is a little different. And so it's not like there's a algorithm that you can follow for each of these. Because as I said, there's subtalar can go either way, ankle can go either way. And so, I think a lot of these are just kind of understanding the mechanism. And sometimes, by the way, it's okay to know that you can't reduce it. I think that's totally reasonable to say to your colleague, hey, I can't do this on the side of the field. And like the previous question, splint them in situ and send them along. Because I think sometimes that delay can be problematic,
Right. Joe, from a sports psychology standpoint, at what point during your treatment of the patient do you have a conversation with the patient that they may never return to their baseline level of performance? Your baseball player, did you ever have that conversation?
Yeah, that's a fantastic question. I think, as you know, Siobhan, doing this with me too, that's probably the hardest part of our job, right? Is telling somebody that the type of injury they have, they may not be able to get back to that same level. And so all of these injuries that were discussed tonight are those type of injuries. So I will say this, I think what I've learned, and you've seen this every day as well, but a lot of our athletes, professional, college, they play through many, many injuries, right? I mean, at the end of a football season, 75% of these guys have some injury that will show up on an MRI and may require surgery. It's pretty remarkable. And so these are really tough athletes, and the way I look at it is my job is not to say you're going to be able to get back to your sport at 100%. My job is to say that I can do my absolute best to stabilize your problem and to return you towards rehab in as quick and safe a manner as I can. And I think that many patients, I don't try to focus on what they can't do. I just try to say, here's what, by this day, you'll be able to try to do this, you know, and I think that's a better way to look at it. I also think the trainers can help you with that process. You know, we have amazing athletic trainers at our university. And often for these devastating injuries, they show up with those trainers. And a lot of my job is to get a sense from those trainers what the recovery has been like, right? So if somebody says every week that goes by, they get a little bit better and I think they're making progress, that's not a patient I want to operate on. But if people who I trust, who are excellent athletic trainers and therapists say, I've seen them every week and every month they get worse. That's the best evidence that I can think of, right? And so in that instant, you can tell that patient, look, there's a risk of doing surgery, of course, but the risk of not doing surgery is that you will never get better, right? And so you have to be honest about that. And my question I always ask my athletes is I say, let's say the injury, let's say you have a high ankle sprain, you're 6 weeks out from injury, and they're back on the field, and I say to them, what percentage of your full capacity are you today as we speak? And athletes are amazing at being able to say that. They'll say 75%, or they'll say 85%. And then I'll say, okay, well, I can't make you 100% if I operate until 6 months from now, right? Or ever, right? And I think that's the honest discussion you have with these athletes. But it's very much psychological. But what I've seen are the athletes who perform at the very highest level have already overcome something, right? They're not people who just woke up one day and were just gifted and just happened to succeed at everything. They're people who've been through adversity and they've been through failure and they've been through injury. And I think the focus should be on what you can do to make them better, if that's the answer. But for example, the second question, the baseball player, I told him that. I was honest with him. They all know who Bob Anderson is, and I told this particular player that was the assessment. I told him, I said, I've had a few outcomes that I was very surprised by, and they did far better than I would have expected, and they now are in professional sports. And it's a testament to, again, the surgery, I tell them, has to be done properly, but the excellent outcome depends on the patient following all the recommendations and all of the therapy. And I think with those two things together, a lot of these recoveries are very achievable, you know, and it's humbling to play a small role in that. And that's what I tell them. I say, look, my small role is to try to restore your anatomy and to get you back as quickly as I can in a safe manner. But your level of success and your ability to succeed again will depend on your commitment and the relationship you have with your trainers and your therapists. And that's, I think, 100% true, you know? And a lot of that, by the way, that question about sports psychology, that's actually so much of this is I've had athletes who had a bad injury, I fixed them, they were doing very well, but some of these guys just don't want to get back onto the field again, you know? And when you talk about sports psychology, and it's not always the wrong decision, that's the scary part, right? Is like, as a healthcare provider, if your athlete tells you they don't want to get their, you know, tear their ACL for the third time, right? Or get their 14th concussion, sometimes it's okay to say, look, you know, maybe sports, this should be the end of your time. And you just have to be honest with them. And so I try to be as honest as I can. And to me, you know, I end every surgical discussion with the same line, and that is, here are the options, but if you are my sister, brother, uncle, whoever, family member, this is what I would do, right? It doesn't mean it's the right answer. It just means that thinking about it and taking a step back and trying to be as objective as you can, this is what I recommend, you know? But there's a lot of psychology to that. I mean, it's definitely true.
Yeah, that's a great answer, Joe. Thank you for that. And then also, I would also maybe add, Thomas, that, you know, this is where our role is to help, because I mean, the greatest team sport, I would argue, is sports medicine, right? There's a team of providers. So it's not all going to be on the orthopedic surgeons to have this discussion. It's going to be on you. It's going to be on the primary care physician, team doctor, who is seeing these individuals. much more frequently than getting them into our surgical colleagues. So you arguably will know this individual, and just even understanding the basic concept that, okay, here's an athlete, and an athlete identifies as an athlete, you know, their role on the field, on, you know, in the pool, whatever their sport may be. If they have any illness, any injury that pulls them out of that, immediately you have to start wondering about their mental health and check in with them. So if you're worried about them, say, hey, you know what, just come back, check in with me next week. I just want to hear how things are, and have the conversation, have the discussion. And if something's not right, we have wonderful sports psychologists available to us. You know, it's a booming field. And then arguably, you're in fellowship right now. Those of us who are fellowship directors, in the last year or two, we're completely beefing up the education on mental health. So being comfortable asking the questions and not being afraid to say, hey, you know what, there's so many CBT or cognitive behavioral therapies that we can get you, like, looking at this is a devastating injury, but let's help you mind, body, spirit, nutritionally, sleep. Let's set the stage to get you as close to success as we can. So it is a conversation that the surgeons absolutely must have, especially with timelines and expectations. But you play a critical role too, particularly with mental health. So just my plug there to keep after the mental health component of things too.
Yeah, you know, I couldn't have said that better. And, you know, Siobhan, like, you've helped me with a lot of our athletes that, for example, let's say a runner shows up and she has a navicular stress fracture, but she also has eating disorder, and she has, you know, amenorrhea, and she has all these other problems and vitamin deficiencies, right? I can't fix that problem. You know, I can put screws across the fracture, but I can't fix the biology that has resulted from that overtraining and not resting enough. And I think you're right. I think you guys play such a critical role in not just getting them to us, because I don't think that's even the hard part. I think the hard part is treating that person as an entire person. And, you know, I try very hard, as busy as I am, to still take a step back and say, like, is surgery the right answer for you? Like, you know, sometimes these athletes, you know, it's funny, I see this more and more, and you guys probably see this too, but I see high school athletes whose parents bring them in and they'll say, oh, like, my son is, you know, gonna play offensive lineman at XYZ school, and so I spoke to this person and they said, you know, you should be the one to look at his foot problem. And some of these athletes, like, they don't want to play sports. Like, their parents want them to get a scholarship, but I'm like, this is your fourth injury, and you're like, you know, you have a bad problem. You already have arthritis at 18. Like, sometimes these kids, you know, I think there are other outside factors that play into this, you know. So I think you're right. You guys have an opportunity to learn much more about these patients than sometimes we do. And it's a really critical understanding of their injury in that whole person, and not just an x-ray or their foot or ankle, you know, for example.
It's the ultimate team sport. I think it's great. So keeping the best for our athlete in mind. So I think that's wonderful.
Yeah.
Well, Dr. Park, I think that concludes the evening, unless anybody has any last second questions. But with that, thank you so much for taking the time. I know firsthand how exceptionally busy you have been, and we really appreciate this talk, and always love learning from you. So thank you so much.
Oh, it was an honor. I again, if you guys have questions, just reach out to us. And you know, the other thing is, if you guys ever have cases that you want like a surgical example for a talk or something, like, myself or my partners often will have these crazy radiology cases or surgical cases that we can share. And Siobhan, if you ever need those, I have a whole book of cases too. So let me know. You know, sometimes knowing that follow-up and learning that is so helpful for these athletes.
That's great. Thank you. And with that, guys, you can reach out to me through the AMSSM portal, through contact information is there, and I can put you in touch with Dr. Park as well. So thank you all. Thank you for joining in, and I hope you learned a lot, and enjoy the rest of your evening and this week. Thanks, everyone. Thanks, Dr. Park.
Of course, thank you.
See ya.